We have Hunter DO and an internal medicine doctor passionate about providing care that helps build a more beautiful and just community. He is inspired to treat and cure conditions that affect many aspects of people's lives, such as chronic infections and substance use disorders. He finds deep meaning in walking alongside his patients through their struggles, triumphs, and healing journeys. Hunter has been an integral to parent-assisted telehealth and communicable disease research, care, and cure since Oregon Hope's inception. As a primary provider of PAPS program, Hunter works closely with colleagues from community, OHSU, and OHA. His research focuses on understanding and addressing health disparities impacting often oppressed people, and he is committed to creating a more equitable healthcare. Welcome, Hunter. We so appreciate you in Oregon.
I wrote that, but it's a little bit soft. Sorry about that. So here, I'm going to talk about PATS, which I presented here before. But we have big news, which is kind of reconceptualization of what we're doing. So instead of just focusing on hepatitis C and syphilis, we're going to be doing as much as we can comprehensive how we're taking care of people. So much so we even changed the name of the thing to peer-assisted telemedicine for health in substance users because I'm like a primary care doctor, so it doesn't make very much sense to maybe treat only one disease, and we want to be as holistic as possible. So this is what we've done / been doing in PATS for a while now. So we're all over the state. We've got 26 counties where we've at least trained somebody. We've got 18 counties where we've trained somebody, and that somebody has at least started one person on treatment. And you see we're in really big chunks of the state. Somebody asked me recently why we're not in the middle of the state. I think the answer is because the counties are really big, so they just happen to touch each other. We have talked to folks in Deschutes, and we overlap with the Prime Plus peers so closely that we go mostly where the Prime Plus peers are really active. So there's less active Prime Plus teams or less funding for Prime Plus teams in some of those middle of the state counties also. And just to summarize what we've done since 2021 until now, we've got over 1,300 people who we've drawn pretreatment labs for. Many of them had a Hep C antibody positive, but not all of them. And despite that, almost 400 of them have had a Hep C antibody or had a Hep C RNA that's positive. So people talk about the Hep C epidemic in Oregon, like this is real life proof. Our prevalence rate amongst this population is like over a third. It's kind of insane. So, or just under a third, I guess. Of all the people that tested positive, we linked the majority of them, almost about 75% to telemedicine visits. Almost all of those folks get started on treatment. And then we have a big drop off in how many folks complete treatment. That's mostly because it's just hard to find folks afterwards, as you might expect. Same thing with why the cure numbers are kind of low. However, because, as you all know, DAs are so effective, if we start people, we feel really good about the fact that we're curing them. And I'm really proud of the treatment initiation number. Similarly, the 120 people that we've cured, we're always looking for folks who are way outside of the healthcare system. They're 70% of our folks are houseless. They're camping outside in dispersed areas that are just very difficult to even physically get to. They don't have electricity or phones frequently. So these are folks who are not really gonna walk into a different type of healthcare setting, and they haven't. And so I don't think these folks would have got cured otherwise, which means we're saving good chunks of them, saving their lives, which is pretty good. So really proud of our 120 cures there. And then I think I presented this before, but this is some of my favorite data that we've collected, some of our qualitative data from the underlying randomized control trial. Folks had a huge impact in their life, as you see. You see it in the city and the CAP and elsewhere. Getting Hep C treatment is really transformational in a lot of ways, and it's kind of the kicking off point of a new way of living for some folks. This person said, well, I intend to change my whole life, and I just figured getting Hep C treatment was a good way to start. I agree. And then another person had said, I was afraid I was never going to be able to quit drugs. Things are looking up now since they told me I've gotten rid of Hep C and stuff. I'm starting to pull a little bit more strength out of things looking up like that. So this idea that we can capitalize on Hep C as an actionable healthcare outcome, that's pretty easy to do in a lot of senses. and then have that bolster people's overall health is really driving at how we're expanding the program going forward. So what we're doing is expanding our lines of service and expanding our ways of getting service. So we're adding same-day treatment options with some new diagnostic tools and implementation procedures, and we're also expanding our service lines. So not just focusing on hepatitis C and syphilis anymore, but focusing on status neutral HIV interventions, which means we'll provide PrEP to folks who want to get PrEP with us, and we'll provide HIV treatment, or at least a linkage to rapid initiation for folks who want HIV treatments. And then we're also providing same-day access to substance use disorder, which already exists in Oregon, but we're trying to link it together in a little bit smoother way for the really kind of marginalized vulnerable people that we focus on. And then most excitingly, or I think it's super exciting, access to actual mental health care with licensed independent prescriber through care system telemedicine. So these are things that, especially mental health care, we've had peers sort of clamoring for years, and I'm always saying, like, well, we're not really set up for it, all this. And now we can be. So it's amazing. There's a good example of when you're doing a lot of community engagements kind of routinely, and then the biggest grant that you've ever seen comes through the tightest timeline that anyone's ever asked for. Because we were talking to folks all over the state, we knew what they wanted, and so we were able to throw a grant together really fast. So that's this grant. So it's a Substance Abuse and Mental Health Services SAMHSA, Mental Health Services Administration SAMHSA grant. And what we're really trying to do is take peer-assisted telemedicine and all the things we've learned about it in the Hep C space, and I think they're really gonna translate well into these other spaces. I'm basically betting my career on them going well in other spaces, so I really hope they go well. But also, I think our patients really need that. I think we need to be innovative and being willing to rapidly implement good pieces of evidence, rapidly put it into practice in a widespread way. So we our peer-assisted telemedicine will help substance users immediately kept active. So this is our same map, and I told you there's kind of two components. One is expanding access to all of these service lines that I just mentioned, but also the same day, bolstering our same day capabilities. So that's actually really the focus of the SAMHSA grant, the same day services. So what we're doing for that is having 6 pilot sites around the state. So they're in urban and rural areas, and what we're doing at those sites is implementing same-day hepatitis C testing with the hepatitis C Cephia device called the Gene Expert that gives you a HCV diagnosis in 60 minutes. So right now that takes like at least a week on a good day, probably 2 weeks to get a Hep C confirmed diagnosis. The way that we currently use either phlebotomy or dry blood spot testing, we're going to shrink all that time down into 60 minutes. Also, we're instituting in these 6 sites community access to FibroScan devices or transient elastography that can be administered by a not radiologist or ultrasonographer and collected in the community. We're putting 6 of those devices in place so that while people are waiting for the result of their Hep C test, they can also get the FibroScan done, which means we're done with fibrosis screening, and we never have to puncture them for phlebotomy. So we're starting this in a phased way, starting in Multnomah and Coos, and then also with our partners in Washington County who already have. So in Hillsborough, or at Washington County Health Department, they already have the Cephia device. In my clinic down the street, I already have a FibroScan, so we're doing a kind of a hybrid model in Washington County so we can learn about doing it and it's already set up. So that's where the stars are. Over the 3-year life of this grant, that's where all the pilot same-day sites are going to be. But the whole rest of the state, everybody in the state that is otherwise engaged with us and has access to these other service lines that I was telling you. This is text, so if you want to reference back to it, describing what we're talking about. The key is that we're using like a one-stop shop model, which is actually an evidence-based term, which is fun to say. But some folks who I collaborate a little bit with in University of Miami have finding that people want that. People who use drugs want to just go to one place and have stuff available. In Oregon, I think it's complicated because going to one place in a rural area is actually exquisitely inconvenient. So what we need to do is bring the one place to them, but it's the same concept. that we can offer kind of a one-stop shop. A way of thinking about what we do is we've always been centered on this relationship between the peers and the clients, and that stays the same. And now we kind of are layering different approaches on top of one another. So all the work that we do really comes down to the relationships that the peers build with the clients and the services that peers can provide. So like I mentioned, we're really built over top of the Prime Plus network, and we work with other peers as well. But the peer services really form the baseline layer where there's a lot of trust being built and a lot of facilitation of basic needs so that folks can have enough capacity in their life to deal with getting medicine treatment or any other type of treatment. And then similarly, peers help with navigation, so lots of different services in the local community, and has layers on top of that by offering an easy route for peers to go in order to find these types of healthcare services that are otherwise frequently really difficult to find in some of these communities. So just to highlight that we're doing all these types of different telemedicine care now, in addition to the diagnostic and testing. And then in the background, a lot of my time is spent on hearing what is happening and looking at their ways to counter it and display it to other. So we already have 9 sites we're doing dry blood spot testing in the States. And that's, I would say, going pretty well. There's been some hiccups getting people to do it. It's kind of hard. Except the folks from CCC for teaching me how to do it and teaching us how to do it. But it can be kind of hard. I think also this new device, the second device, can be kind of hard to actually get enough capillary blood. I think the hard is worth it because phlebotomy is also hard. It's not like there's an easy option really until we get like a whole swab machine, which I don't know if that's even in development. So that would be just another exciting component of what we're doing is that at these 6 sites where the little stars were, we're hiring a new role and a new type of job. So this is called a peer site coordinator. It's a person who's a peer, licensed as a peer, and then we're especially training them to operate these fancy machines. So that's kind of our approach to this idea of like peer creep is that like keep asking peers to do more and more things and not compensating them. Our solution to that was to create a new job that's only open to peers, but compensating people. And we're doing that in this grant mechanism for now. And let's see. We do have some specific goals. It's really important to us to cure 50 to 100 people per year. Actually, the 3rd year of funding is contingent on curing at least 51 people per year in the first 2 years. So 102 is my favorite number. And then we have certain implementation metrics. We're looking at how widely we can implement our HIV screening and linkages to care programs. We want to treat at least 100 folks a year for mental health concerns with at least a brief intervention and link 50 folks to medicines for opioid use disorder or medicines for alcohol use disorder, or medicine or other substance disorder treatment, at least 50 per year. Oh, the last point is really important. The last goal that we have is to transition people back to long-term care in the local community. Almost all the communities we work in have good solutions for getting folks care. I've found, and I think our qualitative data from the Oregon Hope study bears out that it's not that the system doesn't exist. It's just that the class of person or the type of person or the optimal patient that we're looking for is not able to get to that system. But my hope is that by providing more comprehensive services, we can give people good healthcare experiences. And maybe they can successfully start PrEP, or maybe successfully start UC, or successfully get Hep C cured. And then also they can get enough mental health care that they can be sort of stabilized so that they're able to enter into the regular healthcare system, the already existing healthcare system in these local towns. So that's, I think, really obvious how it's going to work with HIV because we link to lots of great HIV providers that are already active in the state and HIV case management through HIV Alliance and others, but including in the mental health care system, for example. I think we were able to help folks get rapidly linked to care, overcome a lot of those barriers that are sort of insurmountable when folks are first trying to get into care, overcome those barriers rapidly, stabilize folks, and then get them plugged back. We are doing some work from the implementation standpoint, thinking about where to implement We are mostly working with Prime Plus peers. The Prime Plus peers have a lot of advantages in their sort of compensation structure for why it's favorable for them to want to work with us in PALS. But we will work with any types of peers that are interested, and places that will do well with us are really active in outreach and engagement. So the teams that do successful work are out in the community, not just in the office or at the desk, so to speak. They also have to have transportation for folks. They have to approach things with this positive change orientation, where we'll do anything. We want to support any change that is an overall benefit to somebody's health without imposing certain goals, for example, with abstinence. And they also have to be able and comfortable with the concept, at least, of assisting with infectious disease testing, and we offer some support that as well. So we just started this October. I think we got the money on October 1st. The government shut down on October 3rd, so it's like perfect timing. And so we're just getting started. We're hiring people right now. We're finishing subcontracts. We're not doing all of this stuff quite yet, but we will be soon. And there's 3 or 4 outstanding hires that we need to complete that'll enable us to coordinate the system on a bigger scale. And then after that, in the first third of next year, we're going to be looking at, or the first quarter of next year, we're going to be looking at building up our protocols and trainings and starting services. Our approach to starting things is just kind of do it and like figure it out as we go and then protocolize it. So that's kind of what we'll be doing slowly. So you're not going to see a huge flood of change right away in the first quarter of next year. And we'll be up in earnest towards the second half of next year through the 3-year life of the grant. That's all of our updates. So thank you very much. We're really excited and happy to chat if you've got any further questions after this.
I think you missed at the beginning when I said that this program, the Oregon Hope, actually started from this meeting. So we can make things happen in this meeting. Meg, did you have a question?
I did. I was going to ask Hunter. Hey, I think you probably told us this, but how are you getting away with not getting them Hep B, SAG, and HIV?
Oh, we're still doing that. We're doing dry blood spot testing for the Hep C surface antigen
Okay.
and Hep C core, and we're testing. So we're going to collect a dry blood spot at the same day we're starting that we collect the Hep C. Then we're going to do the telemedicine visit right as soon as they turn positive for Hep C. So we'll do the telemedicine visit without the knowledge of the Hep B test.
Yeah.
But by the time they get the medicines in the mail, we'll have the result of the Hep B
yeah.
test.
Okay.
And then we can just add whatever they want to.
Right.
I mean, there's very little Hep B. So I think it's not going to be that common of a problem.
Sure.
It's not particularly dangerous to take like a few days of Hep C medicine without Hep B on board anyway. So I think we're not taking really any risk there. By the time they get them, we'll have a screening that. And the HIV, we're doing point of care HIV screening.
Oh, that's great. And the staff that you work with, the other providers or pharmacies, whatever, the team, like, are they all comfortable with that? Because I feel like on our team, some folks are prescribers are not comfortable with that, and I'm wondering how to get them on board.
That was kind of an agreement we came to just because we'll have it by the time the medicine actually gets there.
Yeah.
So it just doesn't seem very risky.
Yeah.
Well, it's the same folks that do the prescribing review the lab, so we'll like see as soon as the Hep B comes back. Let's say Hep C surface antigen comes back positive. We can either tell them to stop taking the medicine or just do another visit because we have on-call availability. Just see them that same day. So I think we'll be able to. It's a great question, though. It's been a huge vexing problem for like the whole world and same day of treatment. And I mean, a big barrier from the device manufacturer, I think, is that there's not a Hep B test that's similarly rapid in the US. In Australia, they don't really care. They do like nationwide point of care Hep C diagnosis, and nobody seems to be bothered by it, even they have but just the treatment environment is how that type of cowboy is.